Everyone to the January 5th, 2021 COVID-19 clinical rounds, update on critical care challenges and successes. My name is Richard Hunt. I'm an emergency physician who serves as senior medical advisor at the National Healthcare Preparedness Programs in the Office of the Assistant Secretary for Preparedness and Response at the United States Department of Health and Human Services. The purpose of these rounds are peer-to-peer, real-time sharing of COVID-19 challenges and successes. If I'm a clinician caring for COVID patients, the clinicians I want to learn from are those with the most experience. This is a voluntary public-private collaboration. Thanks to the multiple professional organizations who have collaborated on these rounds. They are not intended to be redundant or replace any organization's initiatives. They are intended to be sharing of clinical experience rather than recommendations or guidance. These ECHO clinical rounds you are now participating in are focused on clinicians sharing their successes and challenges with other clinicians. Thanks to the National Emerging Special Pathogen Training and Education Center, NETEC, for their support with these rounds. NETEC has webinars that complement these Project ECHO COVID-19 clinical rounds. Thanks to Project ECHO, Dr. Bruce Strominger and his team for the peer-to-peer learning platform we use for these rounds. Upcoming ECHO COVID-19 clinical rounds are all US noon Eastern time. Thursday, January 7th will be the emergency department series of rounds. That will be an update on emergency physicians with a leader speaker from the American College of Emergency Physicians. Next week, we'll continue with our usual schedule of EMS rounds on Monday, critical care rounds on Tuesday, and emergency department rounds on Thursday. Also, I want to point out that we do have a new HHS Project ECHO series on outpatient therapeutics, and Dr. Strominger will talk a bit more about that in a few minutes, or actually in a few seconds. Bruce, I'll now turn it over to you.
Great. Thanks, Rick, and welcome everyone. Happy 2021. Thanks for taking time out to join us today, realizing everyone's super busy. And thanks to Oren Friedman, Dr. Friedman, for joining us to talk about his experience. Just got to quickly run through the logistics. Most folks know these by now, so I'll be brief. But we really do appreciate your questions and comments, so please put those in the Q&A feature along the bottom of the Zoom toolbar. We'll try to get to as many of those as we can. If you have any technical or logistic issues, put those in the chat. Also, Rick will be asking a crowdsourcing question as we do every session. Please respond in the chat to that question in a few minutes. We are recording today's session, as we always do. Your attendance is consent to be recorded, so thank you for that. There's no PowerPoint presentation today, but we will put the link to the recording on our HHS ASPR clinical rounds website, and we'll share the link to that so you can access that or share it with colleagues. For those who would like CME and continuing professional development credits, we're offering those through the University of New Mexico, where Project ECHO is based, and we'll share the link to the CME survey about 15 minutes before the end of the session. It should also be in the announcement that went out today, and everyone has up to 48 hours to complete the survey and receive instant CME. Just a reminder that these learning sessions are focused on improving patient care and health systems and supporting clinicians. Please let's keep them apolitical and non-commercial. Thank you for that. And a word about the data that you share with us when you register, when you respond to the polls, when you put things in the chat. We take data stewardship very seriously. The data we share with Rick and ASPR is all de-identified. Most of it's de-identified up front, but what isn't, we make sure it's de-identified before we share it. Just a reminder about the NETEC, National Emerging Special Pathogen Training and Education Center. Rick mentioned they're a partner in this series. They have their own webinar series, and I'm sure they'll be starting those webinars up in the next few weeks, but they also have an archive of all their recordings for their sessions. Rick mentioned that there's a mini series focused on outpatient therapeutics that started in December. There'll be a session actually tomorrow, and we'll put a link to the registration. It's going to focus on monoclonal antibodies. In the there'll be case presentations by the Michigan Department of Health talking about their experience with the first 1,500 treatment doses that they've administered across Michigan, as well as a presentation about the nursing home setting and how the delivery of COVID-19 therapeutics, specifically monoclonal antibodies, is going in that session. And there'll be Q&A with a variety of experts. So we encourage you, if you're interested, to join that. Also, the AAMC is a partner in these clinical rounds. They have a wonderful clinical guidance repository that they update every week. So please check that out, and we'll put a link to that in the chat as well. They have a wealth of guidance and resources there. So Rick, back to you for the crowdsourcing question for today.
Thanks, Bruce. Crowdsourcing question for today. Realize we have a really broad audience, usually about a third clinician, physicians, a third nursing, and a third EMS. Many of you work in ICUs, many of you don't work in ICUs, but would really like to get your take on, for your region's ICUs, what is today's most pressing challenge? For your region's ICUs, what is today's most pressing challenge? That's the crowdsourced question. We all learn from each other when you respond, so please do if you are able to. With that, I'm going to ask our panelist, Dr. Seibold, to please briefly introduce himself.
Hi, I'm Harry Seibold. I'm an EM and EMS physician from Helena, Montana, past state EMS medical director, and currently on assignment in the ICU in Odessa, Texas.
Thanks, Harry. It's an honor and privilege to have Dr. Oren Friedman back. He has presented before, was extraordinarily well received, and now in Los Angeles, where things are really tough, he's accepted my invitation to come back, and really appreciate him doing so when he may be busier than he's ever been. So with that, Dr. Oren Friedman, Associate Professor of Pulmonary and Critical Care Medicine from Cedars-Sinai in Los Angeles. I'm going to turn it over to you, Oren, and thank you sincerely for coming back.
Yeah, thanks for welcoming me back, Rick. You know, I think what everyone's seeing on the news, it's real. It's just as bad as it looks on TV, maybe even worse on the ground. We've never honestly been in this bad of a situation in Southern California. This is probably the worst that we've had ever since the beginning of the pandemic in terms of surge and overall acuity, issues with bed allocation. And, you know, a lot of the hospitals are really just at the breaking point. And, you know, in addition to working in the intensive care unit on the main campus at Cedars-Sinai, I'm also the director of the ICU of one of our affiliate hospitals, Marina Del Rey Hospital. So I think, in a sense, I'm getting the perspective of not only at a major quaternary center with multiple ICU beds, but also the feel of what it's like to be at a small community hospital with less than 100 beds, an ICU size of 12 beds, and what happens when you surge at a smaller hospital. And so that's they're both challenges, you know, but they're very, very different challenges. You know, in terms of resources and what you can expand out to. So anyway, so I could also speak to that at some point if people are interested.
Oren, tell me about the differences in those challenges between what you're seeing at Sinai and then what's going on at Marina.
I mean, some of it, I suppose, is really not that much more complicated other than, you know, simple math and sort of like, you know, just bulk resources in the sense that, at a larger hospital like, Cedars-Sinai, you have so many different ICU beds built into the system because you have a neuro ICU, a cardiac surgery ICU, a surgical ICU, a pediatric ICU, a cardiology ICU, and then a regular medical ICU. And so that means that you can sort of metastasize out to the different ICUs, and bit by bit, that's what we did. So as the surge continued, we took over the entire medical ICU, then we took over the entire neuro ICU. Now we've taken over the CICU and the pediatric ICU. We are soon going to be taking over the surgical ICU. And then there was one floor that was kind of a step down, which we've taken over and made into an ICU. So it's just like you keep growing and growing and growing out there. And then the other thing that you can do at a major center, because you have more people on staff, is we just continue to multiply the amount of different medical ICU teams. We happen to go by colors, you can go by whatever, but we always had a blue and a green team. Now we have an orange team and a pink team and a red team. And so they would just keep expanding the teams. So you have way more patients. There's lots of moving parts. It's pretty complicated to figure out how all those teams go. But in a sense, you have some space and you sort of have like deeper wells of people to draw upon. At a smaller hospital like Marina, it's the kind of hospital that didn't even have an intensivist that's physically present during the day. So what happens when an ICU of 12 beds, which maybe doesn't sound like so many, what if, 11 out of those 12 beds are now intubated people who are, with severe ARDS that need things like prone ventilation. So that's really tough because, if you have an ICU that's just private practice pulmonologists and they're going off to their clinic during the day, what happens when at noon, patient B crashes and you're having to make a decision about proning? So that's pretty tricky. I'm not saying that that every place is basically going to have to find their own solution. So I'm not saying I have the only solution, but one of the things we did, this actually dates back to the spring, but one of the things we did is we started creating a tele ICU service really out of thin air. So we took some of the intensivists back at the main medical center. We had them take morning and night shifts. We installed video cameras in there so they could go through the medical record, look at the charts, speak with the nurses, take a look on camera and sort of guide the physicians that were on the ground who were a hospitalist team. So we worked side by side with the hospitalists and sort of did a lot of remote tele-ICU medicine. Now this time around, things have exploded to such a degree that we're worried that that's not enough. And so I started creating, it had to be a moonlighting system where we have intensivists who are going to come spend the night at the hospital and be available to intubate patients, put in central lines and see people, live. And so it's not easy taking people who are stretched at the main medical center and, convincing them to come over to their affiliate hospital. But I think the only way that relationship has so far worked out is because we're sort of joined at the hip, and that anything that can't be done there, we're going to have to absorb at the main place. So it's not like it's two separate problems. So I think, that ended up working out because of our affiliation. I think what's probably a lot more difficult is what happens if a small hospital of that size is not affiliated with a larger medical center. So they don't have anyone that can kind of come in as the cavalry and help take care of patients at night and that sort of thing. Anyway, that's a whole other problem, but maybe I'll stop there and see if there's any more specific questions.
No, that's good. Great response. The transfers I'm just trying to think about, okay, your description plus what I see on the news. Is anybody able to transfer any patient in LA County to another institution? Or is it, you're kind of like stuck with what you got because there's no room anywhere?
There's a little bit of that. I mean, I can tell you, the process is really, really gummed up. It is very, very hard. I mean, we almost have a freeze on any outside hospital non-network, transfers in. What's had to happen is there's an entire team of people that have created very, very now strict criteria about who we're going to bring in. Really non-COVID patients, and then in terms of COVID patients. And at any given moment, one or the other is a bigger challenge. So, sometimes there's maybe a little bit of freedom or freed up, like, clean non-COVID beds. At any time, maybe, somebody or several people die on the COVID units. And next thing you know, you actually have more COVID beds that are free than the non-COVID beds. No, it hasn't been easy. And we've sort of, especially with the small affiliate hospital, which there's just simply no place to grow. It's not like we have any other place to move patients around. When the ICU gets full or the ER gets full, there's just nowhere to go. So you just have to decompress. And so we have an entire listserv of what we call like a decompression list, which is we try to predict when we're going to get full and how to decompress those patients back to the main medical center. And, I can't tell you we found the perfect recipe because, there's two ways to look at this. One is you send the patients to the bigger center in whom you think it's going to be more complicated to take care of them. So you say, oh, I'm going to send the quote unquote sickest patient or the busiest patient. And other times you say, well, let's decompress with the people who you think are more likely to survive, which may not be the busiest patient. So maybe I have a 45-year-old who's right on the brink of high flow nasal cannula, self-proning, SATs, maybe just hitting 90, 91, but pretty good chance that person's going to end up intubated the next 24, 48 hours. But they're young, they have single organ failure. Maybe it makes a little bit more sense to get them to the main medical center because they could end up needing ECMO or they could end up needing CRRT versus taking the 85-year-old who's on 3 pressors, dialysis, but now maybe, we're talking about CRRT. So again, there's not a perfect recipe. So at any given time, I've taken the move the patient I think is going to be more salvageable. I've also taken the move the patient that is exhausting the resources. And some days it's, the ER is actually the bigger problem. We're actually going to move the non-COVID simple DKA patient. And that also has to do with if the COVID beds are really filled up at the main place, what we've done, I think as a lot of places have done, is we've actually separated out sort of non-COVID ICU units. And so sometimes those units are easier to get patients into. Anyway, I feel like I'm going on and on and on here, but I think we're piecing through this as we go. And the only thing I guess what I'm saying as I'm hearing myself talk is having a little bit of flexibility where the same formula doesn't apply even in the morning and the night about who should be moved and who we should try to move.
Yeah, thanks, Art. One big picture question, and then I want to turn over to Harry for his comments, and he's in the middle of his own experience down in Texas right now. And then there's a number of questions the chat that have popped up, and I want to make it flow that way. Also give you a little bit of a break too, Aaron. So since you presented months ago, and I have to look how long ago it was, but it was months ago. How are you handling the response now differently than when, months ago? I mean, what's different, your perspective on what's different, what's working, what's not different now, or what's working, what's not now compared to then?
Well, one of the first things that comes to mind is simple equipment issues. So, during the first response, like many other places, I mean, you were running super short on PPE. You were ran out of those little purple wipe cleaners that everyone loves in the ICU. Bleach was gone. And the next thing, it was one kind of chemical and cleaner that was gone after another. And we were having to use kind of makeshift, alcohol-based, hand sanitizers. And so this time around, we had that sort of first surge. And then like a lot of places, there was a lull throughout the summer where I don't know the details, but clearly the hospital must have been doing some major stockpiling because they kept things still really tight over the summer. So now with this surge, at least one thing that's a whole lot less stressful is you have the normal hand sanitizer, the little things on the walls work. They actually are full of stuff. The PPE doesn't seem as scarce. It's a little less hard to find an N95 if you're going in and out of a room. People are still being careful, but it's just that part at least is better. And then I think, people have gotten more used to the system of getting in and out of PPE quickly in and out of rooms. So that we're not kind of relearning that. And then the protocols are already set in place. So all the protocols about what do we do about handling a cardiac arrest and how do we rule people out and all these kind of things, those are already in place. So now the bigger problem was just sheer volume. I mean, like in a way that we've never seen it before. So just exploding into other ICUs and needing people. And then I think the last thing I would just say is obviously therapeutics have changed. I mean, in some ways, Some ways it's simpler, right? I mean, basically, you're talking about treating a COVID patient. It's like a two-drug thing right now for us. It's like Decadron and remdesivir, Decadron and remdesivir, and that's like all we do, and everybody. I think at the beginning of all this, we love to talk about, oh, it feels like people are doing so much better now that we give everyone remdesivir and Decadron. I don't know, not to be like Debbie Downer. Several weeks into this surge, it still feels awful. I don't know. People still are not getting better. There are people dying left and right, as we were talking about in the chat before we started this program. There are still people who are intubated 3 weeks into this, don't seem to have any signs of improvement lung-wise. So, I mean, the only thing is, I do feel like the more liberal use of steroids this time around has changed a little bit of the course of the disease. That's all. So it's, whereas in the spring, I think when I used to talk, I think I talked about the cytokine storm phenomenon that we would see, and people would get explosively febrile and very inflamed and vasodilated and have these ups and downs as their cytokine stormed. That feels like that's gone away a little bit, and it's probably the steroids that are suppressing that down. But then we've sort of replaced it with another host of problems where, I mean, this is a little bit anecdotal, but it feels like now we're seeing just a whole more host of bacterial superinfections on week 2, we're sort of seeing a lot of bacterial pneumonia and bacteremias and some more sort of secondary infectious problems. Obviously more hyperglycemia and things like that, more delirium, which may be the steroids. So we've replaced it with that. And the other thing interesting, I don't know if anyone else has seen this, is a lot more pneumomediastinum and pneumoperitoneum, which has led to sometimes taking people to the operating room looking for a perforated viscus. I don't know if it's the steroids are causing more tissue breakdown. I mean, we always had some pneumomediastinum, but now it seems like that's all over the place. So bottom line is, I feel like it's changed the feel and the course and the behavior a little bit of the disease, but it does not feel like somehow nowadays, oh, wow, it's great, it's miraculous, we're just extubating people left and right. Not at all. I mean, it still feels awful, and it feels actually worse.
Okay, so the volume, the surge feels like it's worse. If you step back for a second and think about, are more patients surviving or not really? Or can you tell yet? And it might not be where you can even tell, given you're in the middle of it.
Yeah, I can't tell. I feel like I'm too,
Okay.
my role is I've always been too close to it, so I'm not sitting back and looking at the actual numbers. So I guess we'll know soon. I mean, what's really happening?
Yeah.
I mean, the recovery trial says that, Decadron decreased
Right.
mortality rate. So I guess we should expect to see that. But I think what's so hard about looking at any of these numbers, and this happened in New York too, it's like, how do you separate out the effect of the surge and the fact that you, by definition, have to go from a nurse taking care of 1 to 1 to 1 to 2 now to 1 to 3. I mean, back in New York, there were nurses taking care of 6 ICU patients up in the Bronx. How does that affect it? Has the effect that you have an intensivist who was taking care of 12 patients, now taking care of 20 patients, or maybe the intensivist isn't working with critical care fellow anymore. Maybe they're working with a volunteer palliative care fellow that doesn't really know ICU medicine. These aren't
Right.
hypotheticals. What's going on? How do you separate out how that's going to have an effect on the mortality? So maybe it doesn't make a difference that you use Decadron. Maybe it's simply personnel and how stretched those personnel are. So those numbers are going to be like all over the place, and it's going to be so hard to interpret that.
Yeah. Thanks. Let me give you a break for a few minutes and let Harry talk about his experience for a few minutes, and then there's some really specific questions, Aaron, in the chat that I'll go through with you and see if we can get some of those addressed. So Harry, over to you.
Sure. Well, thanks for allowing me to talk. I didn't expect that, but so those of you who don't know me, I'm an emergency physician and an EMS person, but I'm on a large regional response here in West Texas that's essentially through FEMA, and FEMA delves out the staffing of both nurses and physicians. And my role in the hospital that I am really echoes something that Dr. Friedman just said, is I'm working with an intensivist. I by no means try to believe that I have that knowledge base that an intensive care specialist would, but I can offload some of their workload so they can concentrate on this large number of really sick patients. We have early on identified overflow areas even before the first surge, And unfortunately, and well, fortunately, they didn't really need to use it the first surge, but have this fall, everything has been full. We have a tiny bit, I'm afraid to jinx myself and say lull, where we have cleared out some space in our overflow unit. Unfortunately, that's because our long-term patients have either gone to a long-term acute care facility without meaningful improvement or have passed away. But I am able to do art lines, central lines, the chest tubes that Dr. Friedman was talking about, many chest tubes. We've seen that exact same experience with pneumo mediastinum, a huge number. I mean, I've never seen so many pneumo mediastinum on intubated patients. And I think it's a little bit because of these stiff lungs and we're working at higher peeps, but clearly it's not just that. Clearly there's something else that's going on with lung physiology that's causing this. And we have had exactly the same experience where suddenly you see pneumoperitoneum and you go, oh, what the heck? And you have to work it up. But all of the ones so far that we've worked up, there's not been intra-abdominal pathology. It's simply been this extension of pneumo mediastinum, which has been really surprising. So we're really seeing this evolution of the same types of patients that are severely ill, but this continues to throw new curveballs at us, and we're seeing new subtleties in the disease process, which I find fascinating on the intellectual side, but incredibly challenging because it's a moving target. We are in that stage right now where we've just passed Christmas and New Year's, and I'm holding my breath for the next 2 weeks because I have very little confidence that we're not going to see another significant surge and fill up both of our COVID ICUs. And the way we've distinguished those, it doesn't matter what disease process you have. If you're COVID positive, you're going to come to one of our COVID units. Then there are a few people that, unfortunately, the ones that I see get better are the ones that are in the COVID unit, but they're not there because of COVID. They're there because they are SARS-CoV-2 positive, but their main disease process really isn't COVID. They don't have shock lung. They don't have ARDS. They don't have this, stiff lung and inflammatory syndrome. They've got AFib with a rapid ventricular response, and they happen to be COVID positive. Those are the ones that I see walking out. I see very few. I have one patient in the two ICUs, that I have a huge amount of praying hope that you will walk out, and the rest I unfortunately don't feel any confidence about because I see this horrible disease process, no matter everything that we can possibly do to support people, that is continuing to progress. The only thing about our young patients is they can tolerate some of these incredibly low PO2s with max settings and max O2s and all the pressures that we have, and then they can survive that. So if we can get past this stage, perhaps we'll have some modicum of success, but I still believe that's very low. Again, what I'm involved in is a big regional response. We have people at many hospitals across West Texas that are emergency physicians that are trying to assist in any way possible, and whether it be working in an emergency department, assisting the ICU like we do, and sometimes there are folks that are out in field hospitals as well. I'd be glad to entertain any questions or comments from Dr. Friedman, because I think he and I have had slightly different inflections of really the same experience through this second half of the year and the surge involved. And then I was very interested to hear what he had to say and see some parallels to what I'm experiencing here.
Yeah, Harry, that pneumo mediastinum thing, it's validating me a little bit to hear you're also seeing that. I mean, sure, we had that a little bit in the spring. I mean, as you have with every ARDS, but yeah, it's off the charts now. I mean, it's like a constant problem, and every variation of it, pneumomediastinum with pneumothorax, pneumomediastinum without. We had one with a tremendous amount of pneumopericardium, and did a little bit of obsession of whether or not we should try to drain if that patient was in terrible shock. Is this like tension pneumopericardium? And And so anyway, it's given us a whole new sort of challenge to sort of figure out how to deal with. I don't know what you guys are doing. One thing I do is now when I see it, I start repeating the chest x-rays at a sort of a more rapid rate. So maybe Q4, Q6 or something like that, because so many of them have turned from pneumomediastinum very quickly into pneumothorax, and some of them with tension pneumothorax. So anyway, such as it is, this is like, seems to be the problem with the fall.
And I have a very low threshold for sticking my finger in someone's chest when they start going down, and you have any kind of hyperresonance or anything, if because of how we've had to basically use other overflow areas, sometimes it's a long time to actually get an x-ray there. And if you have that high index of suspicion, guess what, my finger's going in there.
Yeah.
And you're probably not going to be wrong clinically, given what we have going on.
Harry, let me ask you first, then Aaron, same question. These are all intubated patients, right? The pneumomediastinum?
I would say no, mostly, but I've seen it on patients with high flow, and yeah.
And for me, at least, I think I've seen a few that have been on high flow nasal cannula, but even if you're on BiPAP or CPAP or intubated, we've seen it's quite frequent. It no longer raises my eyebrows. I just have to pay attention to it and look for the complications like Dr. Friedman was talking about. But when I first got here and start opening chest x-rays, like, holy moly, look at that. And they go like, yeah, so what? They kind of shrug the shoulders because they've been here watching this longer than I have. I've been here just under 45 days. And now you kind of go, okay, yeah, let's keep an eye on that. And it doesn't surprise me anymore, but I've seen it definitely in non-intubated patients as well. And that's why it's clear to me that it's more than just high levels of PEEP on an intubated patient and peak pressures. There's another process afoot that we're not clearly understanding yet.
Yeah, and Harry, I was shocked with your answer. It's okay, not just patients. And actually, I think this is the first time this has come up on rounds. I learned something every rounds, but this is the first time this has come up on rounds. And to me, I'm talking right now to the best intensivists, emergency doc, and it's what you do, like pneumomediastinum. It's what you do. And I think about all these people that we have worked really hard to train up really quickly to try to help us, that don't have that same training to start thinking about pneumothorax, spontaneous or otherwise, and how that, I appreciate your setting the alarm. That's what I'm trying to say. Because yeah, it's totally out of sight, out of mind. No, I'm not treating patients right now, but we haven't heard it after 100 and some rounds, and really important that this, and actually I haven't seen it. I see a lot of what's coming out in the literature, but this one I haven't seen. So really appreciate your, we spent some time on it, and I'm glad we did. The other, I've got one more big picture question for you, Oren. And then I'm going to go to the polls, and then I'll see if I can get to some of the other questions as well. And Oren, we talked about this a little bit in our pre-webinar green room, whatever you want to call it, the crisis care, and the specific question that popped up in the chat. Please address the key parts of crisis care protocol implemented at your hospitals. And I am very aware of the sensitivity around crisis care in our nation. So, Oren, whatever you feel comfortable with is great, and if you don't, that's good too.
Yeah, I think what we've tried to do is to come up with words that sound better than rationing, keeping, so this is such a difficult issue, because I think hospitals get very sensitive about it. And, in a way, it's almost too bad, because I think this is such an important thing to be able to talk about. And I think all of us feel a little bit tongue-tied and a little bit limited about what we're allowed to say. We're doing it every individual institution. But, this is just reality. I mean, this is just a fact that we have to do. And in a sense, you know, when you're in the ICU, and Harry's going to know as an EMS person and in the ER, you are always in a sense rationing care. I mean, you're always trying to take the resources and apply it to the best patient who's going to benefit from it. And you're always trying to counsel families towards that. And I think what we've done, and I think in a positive way, is we've finally really stuck to what we always said we were going to do, but never really did. In other words, you know, at least under California law, you know, we have always had the ability to withhold certain treatment that we thought was futile and thought wasn't going to help. So we were always told that if you approached a patient who wasn't a DNR, but was in cardiac arrest, and whom you as a physician felt that they were not going to benefit from CPR, you didn't have to provide it. In reality, everybody felt like they had to. Everyone was nervous about it. We thought, oh, we get sued. And so it was always an attempt to try to contact the family and sort of convince them why they should be the ones to say it was okay to make the patient DNR when it otherwise seemed obvious. And when DNR, I mean both, you know, no CPR and maybe no intubation. Now we've sort of allowed us to kind of be a little bit more thoughtful and appropriate with how we allocate those resources, in the sense that the conversation goes a little bit less like, I would recommend that with your loved one, we don't do CPR and here's why, to in situations like this, we are not going to perform chest compressions, or we are not going to place a breathing tube. You know, we honestly don't think it's going to help. It's not going to make them better, you know? And so it's just a different way of kind of going around that conversation, which takes you much, much, much further. And it's, you know, we've sort of allowed the intensivists to be the arbiters of this, and to use a little bit more sensibility when it comes to allocation of intubation, allocation of dialysis, and allocation of CPR. And that means that sometimes that conversation will, you know, the family may turn around and say, no, I really, really want that. And you say, well, no, I really think it's a bad idea. And well, I'm insisting that you quote unquote do everything. And so sometimes you do get into that conversation, and that's just our own internal trigger point to say, we're going to rapidly bring ethics in. And so ethics, you know, instead of being the maybe, you know, slowly moving, take a day or two to get a consult, has now sort of upped up their speed and said they're going to be available around the clock, sort of for rapid, urgent consults on these sort of decisions, because the resources are certainly scarce, and they're going to help us, and they're going to give us a little bit more support. So I think for, you know, physicians and nurses and people on the ground taking care of these patients, you know, you need somebody from either hospital administration or from the ethics to back you on these decisions, or else no matter what is said over a bunch of emails, people are not going to feel comfortable, quote unquote, unilaterally, like not offering a certain amount of care. So I think they managed to buff us up a little bit. So, you know, that actually is probably better thought of as like, you know, just more appropriate care or more appropriate utilization. I mean, you know, we all know as medical providers, the people who you would never recommend CPR in because you really don't think it's going to change things, you know, and so it's better, you know, that's a good place to start, is to start limiting the things that we wouldn't recommend even at the outset, you know, which is a whole other level from, you know, the kind of rationing that we think about as being anxious about or nervous about, which is saying, I'm going to take a 72-year-old who may or may not survive and just say, sorry, we're not offering intubation to people above the age of 70 or something like that. We're certainly not there. I think that sort of thing probably happened, and I think it did happen a lot in New York, and nobody likes to talk about it. They literally did have to have hard age cutoffs and that sort of a thing. I mean, it's closer to true rationing versus a matter of just better appropriateness and better allocation of care to the people that are going to deserve it a little bit better. And I think then what I'll finish on is, and this gets back to who do you transfer and that sort of a thing, which is that, yeah, you're going to have to make choices here. I mean, if you have one bed available and you're deciding whether or not, you know, who to take from an outside facility into that bed or who to take from the floor, you know, you're going to just simply have to make a choice. And that means that there's somebody who gets the resource and somebody who doesn't get the resource. And it's a little muddier. So it's a little less clear when it's a decision about who gets that ICU bed, or we've run out of high flow nasal cannula machines. Let's use it on this person versus that person. But that happens all the time. It just is a little less obvious and a little less public. It's just happening a little bit more frequently now, you know, where we all kind of know what's really happening. We're all trying to, like, you know, pick who gets the device. And sorry, one third thing I know, and then I'll stop dominating the airwaves. Cedars, of course, is an ECMO hospital. So, ECMO is a whole other topic about who benefits from ECMO and COVID. And suffice it to say that it's a lot more complicated than your typical ARDS patient, because when you go on ECMO for COVID, you're talking about a month, 2 months, sometimes even 3-month run. So it's a huge resource, a very limited resource, and an extreme time commitment. You go on, this is taking up an ICU bed for months on a patient. So what we've done, we've had to be stricter and stricter and stricter. So it went from, we're not going to put somebody on who's been on the ventilator more than 7 days, age 65 or less, to maybe age 60 less, and less than 5 days on mechanical ventilation. So that just keeps tightening and tightening. We're tightening the belt further and further and further. And that's not because we don't want to obviously help somebody, who's, in refractory ventilation, who's the age of, 62. I mean, it doesn't feel good. It doesn't feel good to not offer it on somebody who's 35, but who's day 11. But it's because we've just realized those people just don't do well. They don't survive. They have a brutal course of 2 to 3 months, and then they end up, having a withdrawal of care. So that's another version of, I would just say, the more appropriateness. We're just trying to hone down on who's going to benefit the most from this particular extremely intensive resource. And then I'll finish on that.
So I have a question for our based on this conversation. Cedars-Sinai and the medical centers I've worked at had robust ethics departments. When I say robust, robust might mean 1 or 2 people yet have something. There are many facilities out there that are dealing with these decisions that may not have an ethicist on board, and I'd be curious to know how they are able to access ethicists or are not for those institutions that don't have ethicists on board. Harry, you had a comment, and then go ahead, Harry.
I'm going to start with a comment, and then I have a question for Dr. Friedman. So my comment echoes back to the discussion the panel had before everyone came on. Again, rationing, you mentioned this. Rationing is a horrible word. We have all sorts of negative connotations. And the way I think of it is really more appropriate utilization. And we in America are so spoiled that for the last 50 years or close to a century, we've really worked with essentially unlimited resources, and we can no longer paint that picture. We can no longer work with that backdrop. And the way I see that we have to look at that is, if we don't use our resources appropriately, then it is unethical to the folks that have a meaningful chance of survival of this, because they may not get the resources because we've been unwilling and unable to make those hard choices. So it's really less about rationing and more about making sure that the folks that have a meaningful chance of survival to a meaningful lifestyle afterwards, that they get the resources that they need. My question for you comes on your comment about ECMO. Our experience here has been that even getting an ECMO bed for someone takes multiple weeks. Does that suddenly then move them out of being a candidate simply because they're that many years on mechanical, or that many weeks on mechanical ventilation, while they're waiting to be approved for an ECMO bed, even if they're identified early on as a candidate, and start to work on that?
Yeah, I think ECMO is going to be one of those things that is, I mean, I cannot imagine any institution that's going to be one of those things that's not probably the most highly resource intensive and limited therapy. I mean, you're always going to have much more mechanical ventilators, much more high flow nasal cannula, much more CRRT machines, but every institution is going to have a certain amount of ECMO circuits. And based on how they set it up, if it's a perfusion run thing, you're only going to have a certain amount of perfusionists. So you're talking single digits at most centers. I mean, some of the big centers, probably like University of Michigan, maybe they can get into the teens and into the 20s of ECMO patients, but that's about it. So Yeah, so sometimes the limitation is simply going to be an ECMO bed. It's going to be an ECMO circuit or an ECMO provider limitation, and that's just going to be it. There is not somebody there. There's just not somebody there. And then beyond that, then there's going to be this like, it's got to be a really well thought out, okay, maybe I have one ECMO bed or two ECMO beds available. Who am I going to put on that? And then that's just going to be super, super strict if that helps at all. And I think, and honestly, really partly this isn't just, how do I put it? This is really, I think, a true medical decision in the sense that, COVID ECMO has just been so finicky and precarious. I mean, there's a recent trial that came out in Lancet in which they looked at about 1,000 patients out of the ELSO database, and they did have a 60% survival, which you could either look at that and say, well, damn, that's pretty good. I mean, that's pretty good for such a bad disease and needing ECMO. On the other hand, it certainly is less survival than what we've seen in the larger clinical trials of just general ARDS. But there's that, and then there's this sort of like true reality or feel of it where I think a lot of centers have had a much worse survival than that. And that even when you do get the survivors, it is weeks and weeks and weeks on the circuit. So it is much more labor intensive and resource intensive than it is on a regular ARDS patient. So whereas maybe the average run from H1N1 was like maybe 14 days on ECMO, here we're talking 20 plus. Most centers say that like expect over a month or a month and a half on ECMO. So anyway, this disease just doesn't respond well, and it doesn't respond quickly. You're sick, your lungs are terrible for a really long period of time. And there is a lot that can happen from the time that you go on ECMO to the time you come off, between infections and other complications that's going to make it so you don't end up surviving in the time that it takes for those lungs to heal. So it's a choice that you just, by nature of it, even if you had more beds, you just should be super, super strict about who you put on, I think.
Thanks, Warren. There was one follow-on question, and Echo, if you're going to tee up the polling, don't put it up yet, but be ready. Warren, there was a question in the chat, follow on the pneumomediastinum and a relationship to steroids. Are all the patients getting with the pneumos on steroids? Do you think there might be an association, or totally unanswered? What do you think?
My only caution here is this is completely hypothetical. This like popped out of my brain in the last couple of weeks saying, what are we doing differently now? Why we're seeing so many more? And that's all I can see is maybe the use of steroids. But I don't want anyone to take that away and say that there's any data.
No, I know. I get it. Yeah. There's no science here.
I'm literally just, this is my thought. This is, brain of Dr. Friedman popping up with this idea that maybe it has something to do with the steroids, but I'm not sure.
Yeah. What do you think, Harry? I mean, again, we're all speculating. There's no randomized controlled trials here.
I think that there is probably a relationship. It is not linear by any means. Not all patients on steroids get this. We've seen people that have been on high dose steroids for other reasons. They've gone beyond just our normal Decadron protocol for COVID that have not had pneumomediastinum or those other things that they've, the other side effect is the horribly labile blood sugars. I believe that it's likely there's some relationship. Exactly what that relationship is hard for me to discern. I have to believe in looking at patients with this, that there are genetic components to our response to this virus that we have not yet identified. Yeah.
Thanks. I remember the pneumo and the steroid as a board question. Because I never looked for it before. Now we're back. All right, so let's tee up the. Let's go ahead and do the polling. There's I think like 4 or 5 questions. They're pretty straightforward. It's not a long, convoluted one. This is like a binary thing, a yes or a no. All right, let's stop there. 56% of you voted, 34% indicated yes, 66% said no. All right, thank you. Next. Vaccination distribution and administration in my region is working well. Thanks for everybody jumping on these really quickly. Actually, just for those of you that haven't been on the EMS series of rounds, we've had quite a few discussions on during our EMS rounds on Mondays over the past month or so, and really have spent a lot of focus on EMS medical directors and their energies being put into convincing EMTs and paramedics that they ought to get the vaccine, and not just like you should get it, but deep dive about why. It's been pretty fascinating to watch. And apparently, I mean, people think that that has really helped turn things around in some EMS systems, which is gratifying to hear. All right, let's see the results on this. 60% voted, and that's a wide distribution. Wow. Really wide distribution. It's like the fewest responses were the neutral ones almost. It's kind of fun to see. All right, next. Okay, what is the most pressing problem you or your region's ICUs are facing today? There's a number of possibilities here. I did a similar poll question yesterday for the EMS session, and I'll share those results with you once we see these. Another 10 more seconds or so. All right, let's see the results. 53% of you voted. And for ICUs, staffing, 49% is the most frequent response, followed by clinician fatigue and or complacency. So yesterday we had a similar question with similar options. It might differ a little bit, but overwhelmingly the fatigue and complacency was the most frequent response in the EMS for EMS providers. All right, next. In the past 7 days, the surge of patients has required our organization's healthcare providers to implement crisis care or crisis standards of care. I mean, the chat's been really gratifying to learn from. And also, I know there's some questions that were popped up that I'm not going to be able to get to, but don't feel like they're undervalued. It's just sometimes it's like some conversations I want to make sure continue to happen rather than truncate them. And I think the crisis care one was worthy for sure. All right, 5 more seconds. All right, let's stop there. 10% said yes, 55 no, 35% don't know. All right, and I think I have one last one, I think. Yeah, one last one. Which is the most difficult to manage in critically ill COVID patients? Another few more seconds. And when we get done with the polling, Harry, I'm going to ask you for any closing comments, and then Oren as well, and then we'll close. Let's stop there. 50% voted pulmonary, for sure. And it, to me, like the journey with the rounds since March, ventilation management was probably the first thing we hit head on. Way back then, and interestingly, I think either the very first or second presentation on the rounds was about ECMO back in March. I think so. Yeah. All right, let's close the polls. Thanks for everyone participating. Appreciate that. So Harry, any last comments before we close?
Just want to thank Dr. Friedman for being here, because those are some really crucial questions as we enter, and it's scary to think of it this way. We're entering the second year of this pandemic, and we're not anywhere near the end of this. I don't mean that to sound depressing, because I think we've learned what we need to do, all of us, to remain successful clinicians and to provide for our patients. But there are ongoing decisions and discussions that we need to make. And I think it's a fantastic thing that we've made the commitment to take this project on into the new year, because I think it's every bit as important right now as it was in April and May of last year. So thank you to Dr. Sturminger and Hunt for continuing the momentum that we've gotten and continuing to come up with important and timely subjects for us to discuss here.
Thanks, Harry. Oren, the comments you made in particular around crisis care and its far reach beyond, are we making a decision about CPR or not? You really hit home for me when I recall making a decision. Am I going to send like the helicopter to one patient or the other patient? It's been around lurking, the whole concept. As we've seen, it's the tentacles of this are everywhere in every reach of medical care right now in places like LA and places that are about to be LA. The one thing I want to, before you get your comment, I guess my final question to you, or not final forever, but like the final for these rounds, because we want to have you back. But so LA County, why it's exploding there? I mean, why it's like it is there, I don't know. And yet you're faced with, it has this feel like New York back at the beginning. It has that same just profound, just slammed. And given, what I've seen on the news, just like everybody else has, airports, et cetera, it's a predictable surprise what's coming in some other areas that will likely be similar to what you're facing. So given the experience you're having now, what would you tell those people that are thinking, well, yeah, it may come to us, or those that might not be thinking about it, but maybe ought to, what would you tell them that they ought to be doing now to deal with the coming storm?
So I think first the answer is it probably will. I think, you know, as best as people try to model this out and predict when the ups and downs are going to be, there's such an unpredictability to this. All it takes is a couple super spreader events. Then the incident gets high enough in the community. Then once the, you know, positivity rate's high enough in the community, then it sort of like passes, like, I feel like it's a point of no return, and then it spreads like wildfire. So it kind of bumps up, then boom, and it kind of explodes. And the next thing you know, you have tons of cases. So probably it's going to happen to you and we have a long time before we're going to have that many vaccinations that's going to start to keep the positivity rate down. So it's going to probably happen. So all I would say is, you know, take advantage of the lulls. There's the lull and then the surge and then the lull again. And you know, take advantage of those lulls to sort of stockpile everything, from not only stockpiling equipment, energy, you know, try to keep your staff a little rested during those period of times, encourage people during those times that this is when you take your vacation, this is when you try to get breaks, and then use those times to prepare a little bit. So, you know, get your protocols lined up, get your equipment sort of lined up, start thinking about how you're going to solve certain problems if you're going to have to like rely on other resources, you know, other personnel. And then I think my only other advice, and not that we're necessarily following all this advice, is sort of do what you can to spread the wealth a little bit. I think what's happened to a lot of places is the burden has been shouldered on certain groups within the hospital. You know, ER gets slammed and hit hard. Pulmonary critical care, absolutely slammed and exhausted. MICU nurses and respiratory therapists, just crushed. I mean, they get absolutely crushed. So if you can try to figure out a way to sort of say, let me figure out who else are intensivists or intensive care trained in our hospital. And maybe we can pull upon our anesthesia people a little bit, maybe pull upon our cardiology people a little bit. And then as we did back, I mean, honestly, we modeled this after New York, which is that, you know, you can rely on sort of hospitalists and internal medicine people to handle some of that, that part of critical care, like antibiotics, talking to consultants, making sure people are on DVT prophylaxis, and handle all that so that you can reserve some of the pulmonary critical care knowledge to who should be prone, what PEEP should we choose on mechanical ventilator. And that way you spare them a little bit. So if you can bring your hospitalists into the ICU a little bit and sort of spare that burden of care. And then the last thing, which we haven't done, which is to try to spread nurses around a little bit, to say we're going to pull from our surgical ICU critical care nurses into the MICU so we can spare our MICU nurses a little bit. So these are just thoughts, and I think take those lulls to kind of plan for how you can spread the burden that's going to eventually be upon you. Because when it comes upon you, then you're dealing with, you know, incredible staff burnout on top of the surge and staff exhaustion. And that's hard to handle in the midst of the chaos. Because what are you going to do? You're stuck at this point. You're deep in it, and now your staff is exhausted, and they're calling out sick, and that kind of thing is happening. So that's what I would say for my advice.
Yeah, the staffing piece that you hit on, and how to take care of them and how to stretch it. You know, to me, it's almost like a centerpiece of the whole surge thing and the whole crisis care thing and all of it. The staffing comes up over and over again. There's not enough, everybody's fatigued, and being able to spread that around. So really appreciate that. Bruce, I know you got to go, but thanks to you and Echo for sure. To our participants, thanks for participating. The chat has really, while I get frustrated about I can't get all the questions to all the questions, I also want to make sure that sometimes we get into these deep discussions that are actually really important for people to have and listen to. And thanks for your patience with that. To Echo, thanks. To Harry, hey, keep doing the good work. Let me know about that steroid thing and pneumomediastinum. And Aaron, I know how hard I don't know how hard you're working, but I have a good feel of how hard you're working, and you and your staff and colleagues in at Cedars-Sinai and LA, and our deep compassion goes out to you and your colleagues, and most grateful for you. You know, it's time you spent, but I think maybe the time you spent may be a force multiplier for some people out there that are about to hit what you've hit. So I'm deeply grateful for
Thanks.
this. Thanks so much all, and we'll see you on the next one. Bye.